nowadays, we do have advanced and precise equipment to measure eye parameters, and based on these measurements, we can calculate intraocular lens power and accurately take these measurements for calculators available also online to achieve best results for IOL calculations in our patients. Actually, not only for RayOne EMV lenses, but also for other lenses, I am usually using not only biometry calculators, so meaning calculator which is incorporated in my biometer, but also I am going online for example, Barrett formula, Kane formula, or Dr. Hill formula. We also have a very good ERCRS calculator, and all these calculators help me to optimize my calculation in terms of taking proper power for proper patient. And also in RayOne EMV, these precise measurements help me to adjust the power of the lens to a particular patient. Recent developments in biometry, meaning optical biometry, and also OCT biometry. These are very precise biometers based not only on ultrasound waves calculations as it was before, but there is an optical or laser beam which can reach the bottom of the eye, precisely measure the eye length, and also give us the keratometry results, anterior chamber depth, lens thickness, and all these stuff are very are essential for IOL calculations, especially in such cases like very narrow pupils, like subluxated lenses, or in patients with retinal detachment or other retinal issues. Here I would like to refer to my slides because I would like to explain what the Monovision is. As Professor Barrett said, it was in early 2000s years that it's feasible to gain additional 1 to 1.5 diopters in depth of focus by incorporating positive spherical aberration without the loss of contrast. And together with a modest level of monovision, this technology could increase the level of spectacle independence while retaining the blended or binocular nature of modest vision with less impact of stereo acuity. I just cited Barrett or quoted Barrett words, but what the monovision offset is. Monovision is the difference between both eyes. Dominant eye is targeted for emmetropia, and non-dominant eye usually for little minus. And micromonovision means up to minus 1.5 diopter, minimonovision from minus half to minus 175 diopter, and moderate monovision is minus 75 to minus 1.25 diopter. And this difference allow the patient to keep stereo acuity, but by utilizing both eyes, this patient can see better for far and intermediate vision, and for near vision, they need just less addition. But of course, for these settings, we usually need, first of all, to know which eye is dominant, but I would like to talk about eye dominance evaluation in my next question. The question also was which offset I typically target. I usually use micro to mini monovision, sometimes for more demanding patients, moderate monovision. But I think up to minus 125 difference, these patients can do pretty well. As I told you previously, RayOne EMV, it is a special lens designed for monovision. Its EMV stands for enhanced monovision. So how to, first of all, evaluate eye dominance? There are two tests, and I'm showing this on my slide. Sensory test and plus blur test. Plus blur test means that I ask the patient putting in the trial frame plus 1.5 diopter in front of one eye while patient is utilizing both eyes. And the question is, which side blurring disturbs more? And this side, when blurring disturbs more, means that this is the dominant side. And the sensory tests are just depicted on those two graphs. I'm mostly using the triangle, hand triangle test, asking the patient to make the triangle from the hands and look first and then the other to the big object like big E or optotype screen in my office, and I'm asking when you use one eye, the object is central in the right or in the left side, and the dominant eye is that eye when the object is more central, as it depicted on the graph to the right. And I'm just trying to repeat that micro monovision is up to minus half diopter, mini monovision to minus 0.75, and moderate up to minus 125. And this is Professor Barrett's choice. I would like you to see some of my slides depicting the results we had. First of all, we ask the questions. Does additional aberration worsen visual acuity for distance because the lens has incorporated spherical aberrations in the center? Does RayOne EMV enables intermediate vision with no correction? And what will be near vision without correction, and what aid is necessary to improve it? Very important issue here is when we do both eyes, which is recommended, we have to check both eyes' performance. And we have to explain our patient that correcting presbyopia is some kind of compromise. So when you see my results or our results, our group results for distance uncorrected visual acuity, mean was almost 0.8, and mean target refraction with binocular implantation was little minus, less than a half diopter. But best corrected visual acuity, when it's depicted in this graph, was 1.0 or even more. And 65% of eyes achieved 0.8 or more, and with best correction, almost all our patients, 93.4%, achieved 0.8 or more. And when we checked binocularly intermediate visual acuity in Jaeger tables, most of our patients had 1.25 or more, majority of them 0.75 to 0.5, while seeing binocularly. And for near uncorrected visual acuity, 67% achieved 1.25 Jaeger. This is intermediate print, as in books. And 100% of patients, when we add a little plus, achieved full vision with mean correction plus 1.5, which is very worthy to underline here, because this correction normally when we use standard monofocal is plus 2.5 or more. And in my center in Nowy Sącz, we also did little study for binocular implantation 2 months post-operatively. Most of our patients had 0.8 to 1.0 and even more. And when you see these graphs, of course, these patients had no retinal or other pathology.